Hello everyone, it's Miss Boyce and we will be talking about observational skills today before we get into chapter 4 regarding principles in assessment skills. So as we're talking about observation skills, we're going to talk about how do we learn how to do assessment and treatment. What way can students help themselves learn how this process happens? So we're going to walk through several different areas tonight. The first is going to be clinical observations, your courses, clinical experiences, teaching in clinic, conferences with your clinical supervisors, and then supplemental readings. So let's go through each of those individually. Let's talk about clinical observations. As probably many of you know, ASHA requires several observations. I believe it's 25 hours before you can go to graduate school. So prior to graduate school, you will have to have several observation hours, and these are really important. Not only does it allow you as the student to know if this is a field that you're interested in, but it also shows you the many facets within our scope of practice, and it starts to give you an inkling into what assessment looks like and what treatment looks like, and what strategies are effective, and how we combine all these different things into one session. And what looks like play maybe to parents is actually several calculated things going on in the speech pathologist's head as they're constantly analyzing what's going on with the client or patient, and how the patient is performing. And one way you can start to learn how to think like a speech pathologist or audiologist is to do these clinical observations. I recommend doing way more than is recommended. Of course, you have to do at least the recommended amount. But observe supervisors, observe a variety of different locations and different settings. You can observe in schools and hospitals, rehab centers, private clinics, lots of different places, and I highly recommend you do that. Initially when you start to observe, you may not understand the therapy process, how it works, what the therapist is looking at, how the therapist is processing the information that they're receiving. You may not understand that at first unless they're talking through that process out loud with you. And so usually what happens is students begin to kind of seek recipes or ways to figure out how to treat a variety of disorders. Sometimes as you kind of start observing, you'll formulate maybe a standard approach to each disorder based on what you've observed. This is very initial level or lower level clinical observation. So for instance, if you watched somebody in the schools and they were teaching K or G, it's a back sound, and maybe they had the child look up at the ceiling so that the tongue fell back, which is where the tongue will need to be. It'll need to elevate and go backwards in order to create that K or G sound. The tongue tip will go down versus up. Sometimes children will use T or D in error for those sounds, which is where the tongue tip will elevate and touch the alveolar ridge. So maybe you see a speech pathologist who is teaching that sound and they look up, okay, and the child creates a sound. And so you you think it's great that they got this sound, and you start to formulate this approach where whenever you see someone working on K and J, you think that is how you target the sound. Now, it can be, and it's a great technique, but there are also a lot of other techniques where you may have to add more tactile cueing. I've used lollipops or spoons before, tongue depressors, where you're actually gently pushing down on the tip of the tongue the front tip of the tongue, to keep it down so it won't elevate, making that T or D sound. So that's another approach. Now, again, is one better than the other? No, it's just there are lots of different ways to target that specific sound. If I'm working with a child who is not speaking, a younger child, and we're working on a nonverbal child. Sometimes we'll use sign language. Sometimes we'll use a picture exchange. The particular approach is going to depend on the patient and their needs and what we've tried before and maybe hasn't worked, so we're trying something different. But just know that initially, as you're learning and you start to observe, you may see one thing and think, that's the thing we need to do for everybody. And that's kind of the initial thought process maybe of someone new to observing. Eventually, it'll get more a little bit more complicated, and it will facilitate, excuse me, your understanding as you're observing more. And it'll get a little bit more complex as far as what you think the approaches can entail. So it's not a one-size-fits-all. Okay, and then you also have your course in clinical methods, and this allows you a lot of insight. This course gives you very specific information about both assessment and therapy processes. After this clinical observation portion, we're going to dive right into assessment, and so you'll start to see very clearly how speech pathologists and audiologists can assess. And then later in the semester, we'll talk about treatment. So hopefully this course will give you a really good understanding and a good initial introduction to what it is we do in the field of speech pathology and audiology. And then next we have clinical experiences. This gives you valuable hands-on practice to build those skills and knowledge. You know, especially as you get into graduate school, you will have your clinical rotations, and that's when you're really going to be able to practice hands-on. You will have a patient of your own overseen by a supervisor, but you'll be able to build that skill set and that knowledge base of what it looks like to assess and to treat patients. As far as the teaching clinic, this provides an overview of the patient population. You can talk about the assessment battery, different treatment approaches, protocols, and strategies. A teaching clinic is a great way. I used to use these with my graduate students all the time, where we did ours during lunch. And so we would talk about maybe a particular concern or something that had arose that week that they needed a little bit more information on. And so I would go in depth. Maybe it was a new patient we had coming up that we were going to evaluate. So we were collectively going through the assessment battery that would be appropriate for that client during their evaluation. An assessment battery is simply the what assessments you're going to do during the initial evaluation to determine what a patient's strengths are and what are their areas of weakness in order to determine if they do have a speech or language disorder. The same would go for an audiologist as well. What types of things are you going to need to do in order to get a clearer picture of that person's hearing ability? And so this may include case history information, parent questionnaires. It would include standardized assessments, maybe language assessments, criterion reference assessments. We'll kind of go through the battery later. But there are a lot of different things to choose from. And so based on the child's age, what the referring concern is, any information you've received from the doctor, you're collecting this battery of assessments or this collection of assessments that you will complete during the evaluation. And then treatment approaches and protocols. strategies. Maybe we in clinic are having difficulty with some behaviors. And so I would do a teaching clinic, meaning an hour teaching on how we can de-escalate certain situations or how we can provide more cues to effectively help that particular child with whatever challenge they have that day. Conferences with clinical supervisors. So as you continue in clinic as a graduate clinician, we're going to use usually very frequent meetings, even if it's a short couple of minutes in between clients. We have I often gave written feedback, verbal feedback, and then these conferences as well. And the conferences were frequent throughout the semester, so the student could gauge their clinical progress throughout the semester, for sure at midterm and final, but usually a couple other informal conferences between then. This is when I helped guide them if there were certain challenges or certain areas that I felt like needed improvement at that point in their clinical semester with me. It was also a great time to talk through what was the plan for an upcoming assessment. What did the student have planned for treatment that week for their patients? And then I can problem solve if with them if maybe there was something lacking in their treatment plan, or maybe they forgot a specific portion that I felt needed a little bit more detail in order to be completed appropriately. And then clinical presentations. I did have this at a couple of my clinical rotations when I was in graduate school. The clinical presentations could be very formal in front of maybe a whole department of rehab specialists, occupational therapists, audiologists, physical therapists, speech therapists, etc. Or it could just be within the speech department. And maybe you were doing a presentation regarding a specific client or patient. Just remember our HIPAA rules that you're not using identifying information. You can talk about the person's age and what the characteristics are, but we're leaving out date of birth, name, etc. Those identifying factors as far as reminding, just a reminder that even when we are talking with colleagues, if they're not directly needing that information about that particular patient, we don't use any identifying information. Now, obviously, when you're talking with your supervisor, that's different because you're talking through, this is what happened with so-and-so, this went well, this is where I could have improved, and you're problem solving through that. But when you're doing clinical presentations, just make sure that you are following those HIPAA laws. And then sometimes I would offer supplementary readings. Maybe it was the beginning of the semester in graduate school, and we were just learning about specific populations. I worked with a large bilingual population, and so at the beginning of the semester, or even prior to the semester starting, I often gave some reading research, scholarly articles talking about children who are bilingual and language development, some of the common misconceptions, being bilingual does not increase or increase the prevalence of language disorders. It is not a negative. It is actually, being bilingual actually increases standardized test scores like ACTs and SATs. So that's a common misconception that still is passed down through pediatricians sometimes. But we talk through evidence-based practice, look at some scholarly articles talking about different research, different treatment protocols, etc. I think it's really important to, not only as a student, an undergraduate student, even a graduate student, observations are incredibly important. Um, Now, if you're just doing the observation, if you're just sitting there, you're walking in, you're not saying anything, you're very quiet in the room as you observe, that alone is not going to be sufficient enough. It's not going to help you understand the process of how therapy or evaluations work. However, if you do them correctly, they're incredibly beneficial. Talk to the supervisor afterwards. Ask them questions about what was the presenting concerns? How have they made progress? Can you think of additional things that might be helpful for them? Try to really use that time to push your brain and synthesize all this information you received in your other courses, and start thinking like a speech pathologist or audiologist. We integrate a lot of material, a lot of information in order to develop our treatment plans and our assessment results. And so I think the other important thing to note as well is that observations are a lifelong process. It doesn't end at undergrad or graduate school. Even a therapist with many years experience, we're constantly observing, and we'll talk about this coming up. So why do we observe? One, we're going to observe to identify problematic behaviors or problem behaviors. This can be related to speech, language, or behavior itself. So for instance, let's say we have someone come in and mom brings the child in, the child's not talking yet. So I'm identifying the problem behaviors. I am looking to figure out what type of problem behaviors, meaning like the troubles, not necessarily behaviors, although that definitely can accompany a language delay. So I'm looking at where are their strengths and where are their weaknesses. Let's say it's an 18-month-old, they only have 2 words, mama and uh-oh. Okay, so their problem behaviors are going to be related to language. But due to them trying to communicate their wants and needs, and they can't because they only have 2 words, typically an 18-month-old has at least around 50 words and is starting to combine 2-word phrases. So only having 2 words is quite a delay. With that, now the child has started hitting and kicking and biting and yelling because they're trying to communicate what they want and they can't. They don't have the language or the resources to do it. So now we're starting to see some behavior secondary to a delay in language. Number 2, we may observe to discover and to identify factors which are causing or maintaining the behavior. Okay, so one great example, I think, Dr. Guntapalli talked about this in previous courses. She specializes in voice disorders. And so maybe she has someone coming in and they are constantly clearing their throat and they're coughing. And of course, that is not a great thing to do with our vocal folds. It definitely harms them. And so she's identifying the problem behavior, the clearing of the throat, and then she's identified factors which may make the problem worse or continue the behavior. Let's say as she's talking to the patient, they identified that they drink a lot of coffee. They drink a pot of coffee a day, and then maybe they have some soda in there as well to keep them awake in the afternoon. All of that caffeine is drastically reducing the amount of moisture and dehydrating the vocal folds. And so they're not going to work as well. And so that's another behavior that's kind of maintaining or adding on to the problem behavior. If we're talking back to the language portion, we might be talking about the child who's not communicating, the child is going, and mom knows what he wants, so she gives it to him. And it's a very common thing, but that is going to maintain that behavior, that difficulty communicating, because we're not encouraging the use of language to get an object of interest. And so we can talk through different strategies in order to help that. Number 3, we're looking at identifying strategies that may modify or help the behavior. So in that case, when he's doing then I'm going to take him over, point to the object, and label the object for him. Or I'm going to show him hand over hand how to do more. So I'm taking his hands and doing the more sign for him. And then I try that a few times. And then we play with bubbles. And I show him more once and blow the bubbles. And we go to do it again, and I hold the bubbles right here. And I'm waiting, and he does it on his own. I'm identifying that the signs are going to be a positive strategy for him in order to help with the problem behavior of the language loss and the secondary behaviors because of the language loss. And then number 4, we're observing in order to assess the effectiveness of therapy on speech and language behaviors. So even as speech pathologists, every single session I see a child, I'm constantly observing. I'm reevaluating, is this strategy working? Do I need to change it? Did I make it too difficult today? Or have they mastered that that particular task, and now I need to make it more difficult? So we're constantly observing. If a child has 80% or more accuracy when we're working on S, and now they're keeping their tongue behind their teeth, that's a good thing. So what we're going to do next is we're going to bump it up and make it more difficult. I'm not going to stay at the word level. I'm going to constantly observe and then make it a little bit more difficult. And now we're going to do phrases. So instead of sand, I'm going to say white sand or hot sand. And so I'm adding another word with it. And then we get to sentences and we continue through the hierarchy, but we're constantly observing to determine if our treatment is effective, and if it is, what we need to do to modify it to make it a little bit more challenging or easier if it's too difficult. The common factor with all of these reasons to observe is an appropriate and accurate description of the behaviors in question or the difficulties in question. Okay, so with all of those, our goal is that we are making sure that we're constantly observing for the benefit and well-being of the patient's care. So we are caring for the patient to help with language, speech, swallowing, voice, hearing, all of that. We want to constantly observe and continue to observe so that we can adjust our therapy accordingly. Okay, and then how do we do that? How do we use our observation skills to help modify the client's behavior or the client's difficulties, the client's weaknesses, whatever the delay or disorders are? So Silliman and Wilkinson suggested that we use the series of snapshots when we observe through different lenses. And the lenses are going to show you different views of the client's behaviors. And this is especially important. When you're observing, I'm sure you have had other observations before this course, but especially after this lecture, when you go to observe, remember these 4 lenses. We'll go through them here in a second, because I think it's really going to show you a different way to observe and give you more information about what may be going on with the patient and how you can kind of walk through that process with the supervisor, even if they are not able to talk you through the whole process itself as the therapy is taking place. So let's talk through the micro or close-up lens. This is going to focus on a particular skill that the child either does or does not perform. So they either can repeat the question or they cannot. They either can say ball or they cannot. They either can answer comprehension questions following a story or they cannot. They can place the ball inside the box when you ask, or they cannot do that. It's a simple, can they do the task or can they not? It's looking at maybe the examples below talk about maybe the child can follow one-step commands, so put the ball in the box, but they can't do two-step commands yet. Put the ball in the box and then give me the bear, okay? And then we have the close-up lens. So the close-up lens is going to focus on the social circumstances or interactions that affect the client's performance in whatever skill area you're focusing on. So for instance, this is going to look at what either supports the client's performance or what hinders or compromises that performance. It could be related to cueing, prompting, modeling. So for instance, let's say I'm working on the K and G. We talked about that earlier. And I'm doing k, k, and I'm showing them, giving them visual cues. You just put your tongue back there like this. And it's not helping them. And that's, you give more feedback than that. But I'm making it in the back. See, look at my tongue. It's way back there. We're going to keep it back. And then we're going to keep your tongue down. Keep the front of your tongue down and the back of your tongue up. But that's not enough. It's not helping. Okay, so we need to add additional cues. We're looking at the close-up lens. What additional cues do we need to provide in order to promote success? So I might add some tactile component. I might grab that lollipop like I talked about before, and I'm going to place it right here. Okay, versus see the difference? So T, my tongue's going up, and K, my tongue tip goes down, but the back of my tongue goes up. And then that lollipop or that sucker can sit right on the tip gently. You would do it as the clinician, or not you as the student, but as the graduate clinician or the supervisor may put that tongue tip down. So now I've provided some tactile cues, and that's what promotes their success. Now let's say I take it away, because I'm constantly trying to figure out what's enough cue and what's not enough. And so I take it away and they can't do it. Okay, we need to stay there. We need to go back to providing that cue. We want to make sure we're promoting success and not frustrating them through multiple failures. And then how does the child or the client interact best? Let's say the client was doing really well, and all of a sudden, after several sessions, they were doing really great, and then they had a really rough day. They weren't listening, they weren't attending to the task, you could barely get them to practice G and K, and you realize, today was the first time I had someone observing in there. Maybe the addition of the person doing their observation really threw off the child. Maybe they were nervous. Maybe they were embarrassed. And so you ask the person who's observing to wait in the hallway, and you notice the child after a few minutes is doing much better. Okay, so that's another close-up lens. You're looking at maybe the social interaction or circumstances that affect the child's performance. Okay, and then we have the regular lens. This is looking at the nature of the activity. Okay, so the first lens we looked at, the micro lens, we looked at just can they do the task or can they not? Okay, and then the second lens, the one we just looked at, was the close-up lens. We're looking at the social circumstances affecting the client's behavior or performance. Now we're getting to the nature of the specific activity. So I'm looking at broad skill set. Does the activity require visual, motor, or auditory skills, or all of them? Does it require, what is the complexity of the activity? So for instance, if I say, I want you to touch your nose, okay? Touch your nose. And then I say, I want you to get the pen, or give me the pen if we're working on following directions. And then I say, I want you to touch your nose before you pick up the pen. Okay, so I might have increased the complexity of the task without knowing it. So they may be able to pick up different objects, but now I've increased the complexity because I'm having them do one before the other or one after the other, and that may be too much for them. In addition to the familiar or unfamiliar task, let's say we were constantly working on, or we continued to work on directions. Point to the pig, put the ball in the cup, give me the pen, throw the ball. Okay, so single steps. And then I say something like, walk to the front door, or go to the front desk and say hello to someone at the front desk. I have increased that, and it's an unfamiliar task because we had been staying in my room doing that task, and now I'm having them go all the way out of my room to the front office, or the receptionist in the clinic. So it may be an unfamiliar task in which is too difficult, and we can try those, but just know if you're noticing the child or the client is having difficulty, we may need to back up a little bit. It may have been too unfamiliar of a task or too complex of an activity. And then the last lens is looking at the wide angle lens. So this is focusing on the context of therapy. Are we looking at a group or individual session? There's so many different facets and differences between group and individual. If it's just the child by themselves, and then you have a few children together, the dynamic changes. Sometimes children can thrive in the group setting. Other times it's too much and they kind of retreat back and they allow other people to answer the questions being asked. We also look, is it a clinical setting or a natural setting? Let's say I'm working on some activities of daily living. I can do them in my clinic, but can the child do the same thing if I take him to the grocery store? Or I meet mom and him, the child and mom at the grocery store? Can we still follow those same tasks? And we're really looking at how is that context influencing the child's performance, okay? So they may be able to do it in a clinical setting where I have a lot of different details, really structured. But then when we get into a natural setting where the grocery store is loud and it's much bigger than the clinic room, and you have to go up and down the aisles, and there's so many things going on, the child has forgotten the therapy techniques that we had worked on in the safe, quiet space of the clinic, okay? And so context can definitely affect therapy. Does that mean you shouldn't do it in a natural setting? Absolutely not. It means you need to work up to that. So you just might have to add some more transition between a clinic setting and then the natural setting, okay? All right. Why do we need to use different lenses? The biggest part of this is for you as a student observing, you want to look at how is the treating therapist or the graduate student you're observing, how are they using these different lenses to improve the welfare of the client? How are we ensuring that we're pushing them enough but not pushing them over their threshold, their limit? There's a very fine line of where we want to be. We want to encourage them to work and to excel in whatever we're working on, but we don't want to push too much that they shut down. And so by using these different lenses, it can really help us establish those boundaries and look at, okay, if so-and-so is having trouble here, if we're seeing some behaviors, it sounds like we might have needed to add some more cues rather than continuing to push with the same amount of difficulty that they're having. Okay? All right, so this is the end of the observational skills PowerPoint. Please continue for chapter 4. It'll be all about principles of assessment. Thank you so much.